Our keynote speaker this morning is Donna Ah Chee. She's the CEO of the Central Australian Aboriginal Congress, an Aboriginal community-controlled primary healthcare service employing over 400 staff to deliver integrated services to Alice Springs and 6 nearby remote areas and communities. She's a Bundgalung woman of the far north coast of New South Wales who has lived in Alice Springs for 30 years. She's an expert member of the National Aboriginal and Torres Strait Islander Health Implementation Plan Advisory Group, chair of the Northern Territory Aboriginal Health Forum, and she represents Congress on the Alice Springs People's Alcohol Action Coalition. It is a pleasure, and please join me in welcoming Ms. Donna Ah Chee.
Thank you for that introduction. Good morning, brothers and sisters, ladies and gentlemen. I begin by acknowledging and paying my respects to the Larrakia people, the traditional custodians of the land on which we're meeting today, and to their elders past, present and emerging. I'd like to thank ACRM and RDAA for inviting me to speak to you as the CEO of the Central Australian Aboriginal Congress. Congress, as many of you will know, is a large Aboriginal community-controlled primary healthcare service based in Alice Springs. In a moment, I'd like to say more about Congress and share with you some of its proud history. But first, let me turn to the title of my presentation today: Doctors and the Aboriginal Community-Controlled Health Services, working together to improve Aboriginal health. We in the Aboriginal Community-Controlled Health Services really appreciate the support of the RDAA and ACRM in our continuing struggle for health and justice. Your recognition of the importance of socio-economic, environmental and cultural factors in our health, your support for Aboriginal community-controlled health services and for genuine partnerships with Aboriginal people, and your advocacy for a culturally respectful, consultative approach to policy and program development. Your support in these areas matter. Today, I want to recognise and build on that support by outlining to you 3 areas that we need to work to make national progress in improving Aboriginal health, especially in rural and remote areas. First, we need to invest in comprehensive primary health care delivered through Aboriginal community-controlled health services. We need national recognition that these services are the foundation for meeting the holistic needs of our diverse communities. Second, to be effective, we need reliable access to medical expertise that doctors hold. And to get that expertise, we must ensure that the well-trained doctors are available wherever they are needed. And that means especially in remote and rural Australia. Last, we need a stable national policy and political framework for dealing with Aboriginal disadvantage. We have a blueprint for this. It's called the Uluru Statement. The Uluru Statement and the work of the Referendum Council that led to it gives us a path forward for addressing the deep-seated disadvantage that many of our people still suffer, and holds out the promise of a more effective policy-making process that includes rather than excludes us. It gets to the heart of addressing the marmot control factor, which we know is so important to health development. Let me start with the first of these 3 points. We need to invest in a comprehensive model of primary health care delivered through Aboriginal community-controlled health services. We have to start here with the recognition that the conventional health system is failing our people. Of course, There have been some successes. Infant mortality rates, for example, have hugely improved over the last decades. However, despite the Closing the Gap initiative, and despite numerous other policies and programs by governments across Australia, the big picture remains unacceptable. I don't want to quote a whole lot of statistics. As an Aboriginal person, I live my life in the shadow of those numbers. But it is important to understand that the Australian government's own headline health target is not being met. In 2008, they committed to closing the gap in life expectancy between Indigenous and non-Indigenous Australians by 2031. A decade on, these figures show that life expectancy for our people is slowly increasing. However, it is increasing at a slower rate than that of non-Indigenous Australians. The life expectancy gap is therefore widening, not closing. Clearly, something is very wrong here. This has profound implications, especially for rural and remote health. We all know that Australians living in rural and remote areas tend to have shorter lives, higher rates of disease and injury, and poorer access to health services to those in the cities. A large part of this city gap in health status is actually an Indigenous, non-Indigenous health gap, because a high proportion of people living in rural and remote areas are Aboriginal. Although we only make up 3% of the Australian population, 1 in 6 people in remote areas are Aboriginal. In very remote areas, we are almost half the population. Take this graph from the latest AIHW report on Aboriginal and Torres Strait Islander health. It shows potentially preventable hospital admissions for Indigenous and non-Indigenous people for the various categories of remoteness. You can see that there is a gradient for non-Indigenous people, those in remote areas, and more likely to have to go to hospital for conditions that could have been prevented by timely access to healthcare. But the figures for Aboriginal and Torres Strait Islander people, the dark blue bars, show how critical this is for us. We are ending up in hospital for conditions that could have been prevented at much higher rates than non-Indigenous people, and the gradient between the city and rural and remote is much more extreme. So if we are serious about improving the health of rural and regional Australia, we have to commit to improving the health of Aboriginal people. And if our national progress on closing the life expectancy gap is failing, if that gap is actually widening, we can expect that to seriously undermine attempts to improve the health of rural and regional Australia. So what is to be done? I'm wary of one-dimensional, simplistic solutions, as I hope you are. But in my view, an important part of the answer is increased and sustained investment in comprehensive models of primary health care delivered through Aboriginal community-controlled health services. Such services are sometimes called Aboriginal medical services and were established by Aboriginal communities from the 1970s onwards in response to the failure of mainstream services to meet our needs. Just how badly mainstream the health system was failing our people is sometimes forgotten, so it's worth revisiting some historical statistics. For example, according to government figures based on the reports of concerned health professionals, the mortality rate for Aboriginal infants in Central Australia in the mid-1960s was estimated at 250 per 1,000 births. In other words, 50 years ago, well within the lifetime of many of us in this room, a quarter of Aboriginal children died before their first birthday. Even in the mid-1970s, the rate was 60 to 70 per 1,000, worse than all but the most disadvantaged developing world countries today. Today, the rate has fallen to around 10 deaths per 1,000 live births, as Aboriginal health services have dramatically improved access to primary, secondary and tertiary healthcare. It was to address the suffering behind these numbers that Aboriginal medical services were established by our communities across Australia, often initially with volunteers, later with government, usually federal government funding. The AMS has embodied a new model of service delivery under the leadership of community-elected boards and in keeping with a holistic conception of health derived from our diverse Aboriginal cultures. The new services promoted a comprehensive model of primary health care. This included an emphasis on culturally safe practice and a multidisciplinary team approach to service delivery in which Aboriginal health workers worked alongside nurses, doctors and other care professionals. Aboriginal community-controlled health services were also and remain a powerful statement of self-determination. In rejecting of the notion that health is just about the absence of disease to individuals, they committed themselves to addressing the social, economic and political causes of ill health. Aboriginal community-controlled health services were campaigning about the negative effects of poverty, lack of education, poor housing, discrimination, racism and dispossession long before the term social determinants of health was being used in academia or it was recognised by policymakers. Advocacy, being a voice for the communities we serve and speaking out against these underlying drivers of poor health, is in the DNA of Aboriginal medical services. These twin pillars of Aboriginal community-controlled health services, multidisciplinary, comprehensive primary health care and advocacy, continue to this day. Access to high-quality care is vitally important to treat illness, but of course, this alone will not close the gap. We also need to address the underlying social determinants of health, including overcrowding, early childhood and educational disadvantage, unemployment, alcohol and other drugs and others. It is this both and approach that is the hallmark of comprehensive primary health care. Central Australian Aboriginal Congress is a good example. We began in June 1973 when over 100 Aboriginal people from town, both and bush, met to discuss how to safeguard and promote the interests of Central Australian Aboriginal people. Based on the Indian National Congress of Mahatma Gandhi, our Congress was established to be a voice for the Aboriginal people of Central Australia on all matters that affected them. Our first service was a tent program providing shelter to Aboriginal people camping in town. In 1975, Congress started a medical service in a house in Alice Springs, and a doctor was employed and transport and welfare services set up. Dr. Cutter, the first of many doctors to work for us, was an inspirational and committed man who earned the deep respect for all he worked with. The combination of Aboriginal community, cultural knowledge, Aboriginal governance, management and leadership, and compassionate, quality medical care proved to be a profoundly effective combination. Today, we take a life course approach within a culturally safe and responsive framework. We are one of the most experienced organisations in the country in Aboriginal health, a national leader in primary health care and a strong advocate for health of our people. We are a $50 million organisation that provides services to more than 15,000 Aboriginal people each year, which is about 80% of the Aboriginal population of Central Australia. Congress has 14 clinics both in Alice Springs and 6 surrounding communities. We still ruffle some feathers when we speak out on issues. That is how it should be. This part is why we exist. And while this has sometimes sat uneasily with government, they increasingly have come to recognise that community-controlled health services are the best practice service platforms for addressing the complex health and wellbeing issues of Aboriginal communities. Recent evidence and literature reviews have attempted to assess the effectiveness of our community control model in comparison to mainstream primary health care. In doing so, they've been hampered by the fact that our service population has significantly more complex needs and frequently live in rural and remote areas where private practice business models struggle and service access is a particular challenge. In addition, our comprehensive model of care goes beyond the treatment of individuals, clients, is quite different to that offered by most mainstream services. Nevertheless, the evidence points to ACHEs as highly cost-effective, with a major study concluding that, and I quote, up to 50% more health gain or benefit can be achieved if health programs are delivered to the Aboriginal population via Aboriginal community-controlled health services compared to if the same programs are delivered via mainstream primary care services, unquote. Therefore, the first area we need to address, if we are serious about tackling Aboriginal ill health, is to increase resourcing to strengthen and extend Aboriginal community-controlled primary healthcare services. The focus on funding single issues and vertical programs needs to stop. This brings me to the second policy area we need to address. We need reliable access to the medical expertise that doctors hold. I mentioned Dr. Carter before, who played such an important role in the early days of Congress. Doctors remain an essential part of a holistic, multidisciplinary model. Our service cannot run without them. We need doctors who are well-grounded and competent professionally to deliver medical care that our people deserve as Australian citizens. We need doctors with the skills to be able to sort through the multiple conditions that so many of our people present with. But at the same time, the doctor must be able to see a person in front of them, not just a collection of symptoms. We need doctors with a commitment to social justice, but at the same time, they need to be pragmatic, to be able to translate that passion into practical action. We need doctors who can work as part of a team, but who can be courageous and speak out if they see a problem and offer solutions to enter into a dialogue with us. And of course, in order to get doctors with a complex mix of skills, we need to address workforce issues to ensure these doctors are available wherever they are needed. And that means especially in rural and remote areas. Undersupply of doctors in remote and regional areas has been a consistent challenge for our sector for decades and is recognised as a significant barrier for improving the health of our communities in those areas. While I was preparing this paper, I looked at the latest Australian Institute of Health and Welfare report on Australia's health to get an idea of the scale of the problem. I was shocked, however, to see the following graph. It shows the number of employed health professionals by remoteness area. If you look at the third set of bars from the bottom, it would indicate that there are considerably more medical practitioners per head of population in remote and very remote areas of Australia. Now, this clearly can't be right. We know, for example, that in the Northern Territory, Northern Territory has places for 55 registrars per year, but consistently only around 35 of those have been able to be filled. Congress, one of the largest community-controlled health services in the country, has the capacity to devote significant resources to attracting and retaining our doctors, yet we are still reliant on doctor registrars to fill some positions. Noting, though, that doctors who do tend to stay for an average of 9 years. We have at least 2 unfilled permanent doctor positions at any one time, and often more. Now, I understand that there are data sets other than the one that the AIHW graph is based upon such as those based on Medicare billing, which tell a more realistic story about undersupply of doctors in rural and remote Australia. However, this graph underlines a real problem with formulating evidence-informed policy, something that we at Congress are committed to. If the data being reported by the preeminent health data experts in Australia is giving such a distorted picture in reality, I think there needs to be some solid work to get this right. In terms of trying to address the real situation of undersupply of medical practitioners, I know that numerous policies over the last couple of decades have looked at ensuring a distribution of doctors more in line with the health needs of Australian citizens. This is a complex area and one in which I do not pretend to be expert. However, I can speak from considerable experience of running a large health service in a remote centre. And clearly, what is in place at the moment is not working if the experience of services on the ground is anything to go by. So I would suggest we need to look at the problem on several levels. First, we need to encourage those studying medicine to go into general practice rather than specialise in other areas. Of course, we need other specialists too, but when we are talking primary health care as the key investment to improve the health of our people, it is the general practitioner and their work within a multidisciplinary team that is fundamentally important to us. Once we have addressed this, we need to encourage doctors to commit to the rural pathway. I'm sure there are many of you who have wrestled with this problem and its complexities. I have a few ideas that I think are worthy of serious thought. First, I would like to suggest a campaign to Medicare to provide a rural and remote loading for MBS payments as a key way to encourage more doctors to relocate to regional and remote Australia. GP remuneration in cities has increased a lot relative to rural and remote areas, as high throughput service models have expanded in ways that are not possible in servicing rural and remote Australia. There has to be a significant financial advantage to go to rural and remote, and this is not the case at the moment. I also think that bonded medical placement scheme needs to continue and be strengthened. It should require that those whose medical training fees are fully waived commit to becoming GPs through the rural training pathway and then spending 3 years post-graduation in a rural area. Last, Congress has long advocated for the geographical restriction of provider numbers as a non-financial incentive to ensure that workforce supply is more equitably matches population need. GPs who work the longest in areas of need should get preferential access to the sought-after city provider numbers when they choose to leave. I'm aware that this is a controversial proposal and one that is not supported by some organisations representing medical practitioners. However, the health and wellbeing of people in regional and rural areas cannot continue to be undermined by the lack of access to the skills and expertise that medical practitioners can bring to the table. Australia is a wealthy first world nation, and we cannot continue to rely on international medical graduates. We do appreciate their support and the skills that IMGs bring, but as a nation, we have to get our own to come to rural and remote areas. So the second area we need to address is the supply of doctors to our Aboriginal community-controlled health service and to remote and regional Australia. The last area I want to look at is the need to establish a stable national policy and political framework within which sustainable long-term policies and investments can be made to tackle Aboriginal health. We need to ensure consistent, evidence-informed policy which includes our people's voice and experience. We have the right to be involved in making the decisions about those matters which affect us. As one of my board members says, no decisions about us without us. And yet, what we have seen over the last decade or more, a cascading series of policies and programs coming out of Canberra with little or no genuine involvement by our communities. Frequently, we are consulted on issues that others have defined as important, and then decisions are made elsewhere on how to go forward. Often, we are not meaningfully consulted at all. Small wonder why the public policy made in this way fails. Small wonder why the Close the Gap targets set by the government, not by us, are not being met. There is a blueprint for addressing this situation, though. It arose from the recent work of the Referendum Council, one of those relatively rare situations where we as First Nations have been meaningfully engaged. With the blessing of the federal government and the opposition, the Council spent a year holding consultative gatherings of Aboriginal and Torres Strait Islander people around the nation. This culminated in the First Nations National Constitutional Convention at Uluru in May 2017. The overwhelming consensus from these processes was a process to address not just the issues of public policy making, but the fundamentals of the relationships between Aboriginal and non-Aboriginal Australia. It included demands for a process for treaty making to lay a firm basis for the future relationship of First Nations and those who came to this country later, and two, a constitutionally enshrined voice to Parliament to ensure ongoing structures for Aboriginal input into policy making and the life of the nation. Why are these things important for the health of Aboriginal and Torres Strait Islander peoples, and hence particularly for the health of rural and remote Australia? First, there is a strong relationship between disempowerment and poor health and well-being. There is now good evidence that the consistent exposure to stress associated with lack of ability to exercise control in life can profoundly undermine physical and mental health. The formal recognition of a treaty embodies and the self-determinate policies and practices that flow from it would increase Aboriginal people's control over their own lives and can be expected to lead to better health and well-being outcomes. Second, treaties are able to provide enduring and effective institutional arrangements for the provision of health and other services. It has been convincingly argued by the late Stephen Kunitz that the treaties with First Nations in Canada and the United States were fundamental to more effective, stable and sustainable policy and service delivery systems, and consistently to a much narrower health gap than we have seen here in Australia. Last, the establishment of a permanent, constitutionally enshrined First Nations voice to the federal parliament would help end our marginalisation from key decision-making processes. It will continue to be more effective policy making and it will contribute to more effective policy making and program design. And it might just help the government fix its terrible record when it comes to the implementation of the recommendations of many reviews, reports and commissions to which we have contributed over decades. I often argue that the one Royal Commission that is needed is a Royal Commission into why the findings from all previous Royal Commissions have not been implemented. In my view, the offhand and ill-considered rejection of these moderate and practical demands by the federal government typifies everything that is wrong with public policy making and debate in this country. So to conclude, I've outlined today 3 areas where we seek your support for a genuine approach to addressing the continuing poor health and well-being suffered by our people. support for Aboriginal community-controlled health services, support for policies and programs that ensure those services in rural and remote areas have access to the skills and commitment that doctors as key leaders in the provision of clinical care bring to us, and support for the Uluru Statement and its vision of a more just and inclusive Australia. These are critical pathways to improving the health and wellbeing of Australia's First Nations, the original sovereign owners of this country, and through them, the health and wellbeing of rural and regional Australia. Thank you. Thank you very much. Oh, I don't know. No, that's okay.
Come and stand up here with me. That was exceptionally powerful with a lot of, I think you could go for another hour. There's so much information there, there's so many things. One of the I've read a bit about you previously and some letters you've written to the Alice Springs News. And you know, there's a.
Oh, there's one today.
Is there one today? Well, it wasn't that one. But that actually makes a point. So that is, there's that continuous conversation that you have to have that voice out there, and that's something I've noticed is that you do push that a lot. Is that a challenge to get that support there, especially from a media perspective, to get that voice out there? Is that something that you see as easy for the Congress and for the community?
Look, I think, as I said, advocacy is part of Aboriginal people's DNA, and it's an important element of comprehensive primary health care. So, you know, you've got to pick your battles, and so there is you know, media that can give you a good run, but there is also media that is quite racist, and we have to challenge that as well. So yeah, look, yeah.
Yeah, because that is one of the things. You kind of think that everyone is quite equal in the distribution of the message, but that's not the case.
Absolutely not. And we've got at the moment, and you know, the courage position that the current government in the Northern Territory has taken on alcohol reform, you know, in terms of its leadership, not just in this jurisdiction, but for this country. And I think it's the second or the third in the world to be introducing a floor price on alcohol, which we know there is evidence that it works. Yet we've got some media that is running a campaign on the basis that you know, not on what evidence, what the evidence is. So you're always constantly having to justify the evidence, yet they don't have to justify why it doesn't work. Where's their evidence that it doesn't work? So they're the challenges.
Just one other thing. I noticed you mentioned a comment about the 50% healthcare gains in reliable access. The idea that you could get reliable access to healthcare, it actually will show an improvement. And I read earlier a statement that was from a local doctor in our area, the Newcastle, Hunter New England LHD in Sydney, and Erica Chapman Burgess is her name. She's a Aboriginal woman who graduated, had a great struggle to get through there into that, but now says that there needs to be more Indigenous doctors to help close the gap. What is the next step to help to get more Indigenous doctors into healthcare?
I think that well, you know, first of all, I think we've got to start focusing on early childhood because as a social determinant, as we know, you know, getting through education, getting to year 12 and then going on to university, the evidence now about the importance of early childhood and how that can actually impact on your trajectory. And we know that, for instance, in the Northern Territory, the high percentage of children who are developmentally vulnerable on 2 or more domains is impacting on their ability to get that trajectory into going on and doing well in school, in higher education, getting more doctors, nurses, Aboriginal health practitioners, lawyers. So I think we've got to start thinking about coming back more earlier and dealing with the gap in terms of early childhood.
It kind of seems like there's an ecosystem for rural and regional doctors, that they start the conversation early. So as people that are connected to the community, they can encourage that conversation into education, which then encourages into health, which encourages into further education. It kind of seems to be this cyclical ecosystem that we started early and it'll change, it'll make a difference.
Absolutely.
Really interesting to hear from you. Thank you so much for this morning. We appreciate your time. Please thank Donna Ah Chee.